most people get this question wrong. And it is very simple to answer, very simple to score the exam. If you have a good concept on the differential diagnosis, it is pretty simple. Let me introduce myself again. My name is Suman. I did my bachelor's from Bangalore Hosmat Hospital. Hosmat Hospital was the second largest orthopedic sports trauma hospital when I graduated. We were pretty much treating the patient right from the second year up until the fourth year. And by the final year, we were kind of, having our own individual patients. And then we did the same thing in our internship. So we saw lots of musculoskeletal disorders, many sports injuries, because Bangalore has a international cricket stadium, and it also has good soccer fields. So we used to see lots of sports injuries, orthopedics injuries, and then we were learning on the field as we were doing those internship in our clinical rotation. So I just wanted to share a few things I learned, nothing to brag here, just a simple concept that I learned. I thought it might be helpful to you guys as well. So let's just get started with this question here. This is the type of question that you will see in the NPTE license exam. And this question, I pulled it out from the Therapy Aid exam preparation book. This is nothing that I made up or something like that. It is a real question from a Therapy Aid exam. I think it's exam B. So I would like you guys to read this question. I'll give you some time. Just read this question and just read the question and go over the options. And after you read and you just write it down. You don't have to type it down on the chat. You just write it down and let me know when you guys are done reading the question, okay? So we can talk about this. I'll give you a minute or so. I will keep quiet so you can read the question. So everyone read the question there? Okay, good. So yeah, I'm gonna take it from Nidhi and Cassie right here, Priya, Joe, and everybody over there. So let's just briefly go over the question here. The question talks about a patient complaining pain on the right shoulder since falling on the right shoulder about 3 weeks ago. And there was no dislocation, x-rays were negative. And then up until this point, the question is just talking about the background. What happened and what has happened, or what has taken place in the past. And from this point now, the physical therapist is doing some examination. First, he's going to do some active range of motion testing, and he's going to do some passive range of motion testing, and he's also going to do some resisted abduction testing. So you will see this active range of motion, passive range of motion, and resisted isometric testing a lot during the examination, because these three are weapons for physical therapy examination. They are kind of very simple and they give us very basic information, but the information that we get out of that three examination is very crucial. And if you know how to arrange the information coming out of those examination, active, passive, and resisted muscle testing, you'll be able to tell pretty much every joint, pretty much every part of the body, not just the shoulder, not just the knee, not just the hip. If you know this system, you'll be able to answer every question from every part of the body. So right here, they are talking about active, passive, and the resisted isometric muscle testing. And we have to find out whether the pain is coming from capsule or a nerve or a muscle or a tendon, or it could be anything in the option. It can be bone, joint, cartilages, and everything, but here in the option there are capsule, muscles, nerve, probably tendon. So these kind of questions are very common, and it is pretty easy to answer if you know the system. It's pretty easy to answer if you know the system. So let's go about breaking down the system one by one. Before we go into the system, let's divide the tissues. We know that pretty much everything in our body can give us the pain, right? For example, deep inside the body, we say we have bone, and out of the bone we have a covering of the bone, periosteum, and on top of that we have capsules, ligaments, joint cartilages, muscles, tendons, nerves, vessels, skin, and every structure that we have can give to pain. And our job as a physical therapist in an exam or in a clinical field is to find out what is causing the pain. We need to find out what is actually causing the pain. So in order to find out, we have some system that we can follow and we can easily come to an answer. So for the sake of ease, I divided the structure. We can divide the structure into two different categories, like soft tissues and hard tissues. Soft tissues are like capsule, ligaments, tendons, muscles, nerves, and such. The hard tissues, on the other hand, is like bone tissues, joint surfaces. So those are the kind of tissues that we deal with most of the time. And if we go further, we can even divide the soft tissues into two different groups. One that can contract and relax, another that does not have that property of contracting and relaxing. The one that contracts, we call them contractile structures, right? And one that does not contract, we call them inert structures. And the contractile structures, can you guys jump in on the chat and let me know what structure we can count into contractile structures? For example, muscle. Go ahead and jump in on the chat box and just type in what you think comes under the contractile structure. What is MTZ? I'm sorry for the abbreviation. Muscle tendon junction. The junction between the muscle and the tendon and its attachments on the bone and the muscle itself. The entire muscle structure from its one attachment up to the another end of the attachment comes under contractile structure. If there is any problem on that contractile structure, we can do few tests and find out if it is from the muscles or not. The rest of the things are not contractile, and we call them inert structures. For example, capsules, they do not contract. Ligaments, they do not contract. Fascia, contract in the sense active contraction. Okay, fascia, skin, bursa, dura mater, dura seats of the nerve roots. Now these are non-contractile or inert structures. Now there is a simple examination, and then we can narrow down our doubt. Initially, when a patient comes to you with a pain, you have pretty much no idea what might the pain be coming from. It could be coming from the joint or muscle or tendon or capsule or ligament or nerve. We have no idea. A brief history might give us some pointers towards the direction. We can suspect this or that, but unless we do an examination based on this concept, we won't be able to tell. Now we know that there are two different kind of soft tissues. One contracts, the other one does not. Then if you do active range of motion and then see if that's giving pain, then you know it is coming from the contractile structure, right? And when doing active range of motion, it hurts. And if you do passive range of motion, it still hurts. Then that's most likely not coming from the contractile structure. That's probably coming from something else. So let's go and see what it is. Further division of this soft tissue, we can examine the soft tissues by active range of motion, passive range of motion, resisted isometric testing, and just these three tests, and you'll be able to narrow down your doubts. So let's go one by one. What do we look in the passive range of motion? When we are doing passive range of motion, we are actually looking for two things. One is we are looking for a range. How much movement does a person have? Does the person have a full range of motion? Is the range complete or not? Is the range incomplete? Is the range more than what it should be? So we first look for the range. Next is we look for the pain. Does the patient have pain during the movement? Does he complain any pain during the movement? Now let me ask you this question to everyone out there. Let's say you did a passive range of motion for the shoulder. Okay, you did a passive range of motion for the shoulder, and then the patient complains pain. Go ahead and jump in and type in, what do you think could cause the pain while doing passive range of motion? What can be the structure that's giving you the pain? Tendon. Okay, Aisha, a tendon. Yeah, it could be tendon. Go ahead. Anyone else? Non-contracting structures. Very good. Like capsule, ligaments. It could be other thing as well. Go ahead and yes, non-contracting structures, capsules, ligaments. What about joint surface? Do you think when you move passively, a joint will hurt or not? Yes. If the joint has arthritis, if the arthritis is so severe that when you're moving, the joint rub against one another, it might hurt. The cartilages, anything inside the joint, such as the labrum, such as the meniscus, will that give a pain when you passively move? Maybe joint capsule, bursa, yes. So just doing passive range of motion, you cannot just tell, right? It could be anything. It could just be the bone. Person might have a fracture. He might have a dislocation. He might have a problem in the capsule. He might have a problem in the ligament. He might have problem in the joint surfaces. He might have problem on the tendons, which are getting stretched as you move, and it's the patient is complaining stretch pain. So just doing passive range of motion, it does not tell much. But if you combine this with the other examination, we come to we can get a formula, kind of a formula. So let's go and talk about that. So before we talk about that, I would like to talk about, I told you we look for two things in the passive range of motion. One is the range, next is the pain. We said when we move the joint, the pain could be coming from any structure. As long as we are putting the tension on any structure, it could give pain. It could be bone, joint, surface, ligaments, capsule, anything. And what about the range? Okay, now if you combine range and pain, that gives us some answer. What about the range? If the range is limited, if the patient is not able to complete the full range, if the range is limited during the passive range of motion, what does that tell us? Can you please jump in, guys? If the range is limited, what does that tell us? Okay, guys, I want you to jump in on the chat box. Tightness in the muscle, tightness, very good. So when range is not complete, we are suspecting some kind of contractures, tightness, adhesions, or stiffness. Something that is, yes, some obstruction is present. Very good. It could be either inside the joint or outside the joint, right? Any restriction that is limiting the movement can be inside the capsule or outside the capsule. Anything that is inside the capsule, we call it intra-articular structures or intracapsular structures. Anything outside the capsule, we call that extra-articular structures or extracapsular structures. So here the distinction is between either it is a capsule or anything but capsule, and that could be inside the capsule or outside the capsule. Those all things could be stopping the movements. If it is inside the capsule, then that is intracapsular. If it is outside the capsule, then we call it extracapsular. How to tell if it is a capsule or non-capsule? There is again another system. If we follow, we can tell it right away. And we call that, we see a pattern. When we do a passive range of motion in all planes, if we see a pattern, then we can narrow down whether the stiffness is coming from capsule or not. If it is a capsule, then it is a capsular pattern. If it is not a capsule, then it is non-capsular. Now let me tell you, when a capsule is stiff, if this is a joint and that's the surface, let's say glenoid and the humerus, and the capsule is tight, capsule is kind of stiff. When the capsule is stiff, it's gonna restrict movement in all planes. Most likely in more than one plane. Not all planes, most likely more than one planes. Does that make any sense to you guys? So what I just told is, if it is a capsule, then the restriction will be more than in one plane. The range of motion will be limited in more than in one plane. For example, in the shoulder, there is a capsular pattern. The pattern is flexion, abduction, and medial rotation. All these three will be affected, but in different proportion. One will be affected more than the other. If you see this kind of restriction in a joint, then the problem is most likely coming from capsule. If you don't see this pattern, if you just see restriction in one direction but no restriction in any other direction, suppose for a wrist, if you see restriction on wrist extension but there is no restriction in another plane of movement such as radial deviation, ulnar deviation, flexion, or circumduction, then that means capsule is totally fine. Now you ruled out capsule. It is not the capsule. You don't have to worry about the capsule. What you can think of next is anything but the capsule. Does that make sense to you guys? If I'm going too fast, just ask me to slow down, pause, ask me any questions. So what we did is, okay, good. So up until this, we did range of motion restriction can be, yes, if the range of motion restriction is one direction, then it is not a capsule, most likely, okay, I will come to that point. Not always, but most likely it is not capsule. It's something else that's restricting. Let me give you an example here. So this is a wrist extension. If you guys can jump in on the chat box, do you know what is a capsular pattern for the wrist? If the capsule is involved, what kind of restriction do we see and what kind of pattern do we see in the wrist? In capsular dysfunction, defect in intrastructure, or what? Shruti. Flexion and extension, same. Aisha just texted me saying if wrist is affected, then the flexion and the extension both are affected in the same proportion. And Shruti just texted me, in capsular dysfunction, defect in intra-articular structure, or what? Shruti, I didn't get your question quite well, but let me try to explain what I just did and see if that helps you. In a capsular dysfunction, range of motion is getting limited in more than one plane, just not on one plane. Probably in flexion as well as in extension in the wrist. For the shoulder, flexion, abduction, and medial rotation. If we see that pattern, then we call that as capsular pattern. And every joint has its own pattern. And you have to memorize and remember the pattern for all the joints. Okay? So, if we see this pattern, then we call it capsule that is at defect. If the capsule does not show this pattern, then we might say something else is at problem. It could either be anything inside the capsule, such as intracapsular structures, for example, subluxation of the joint, or it could be anything outside the joint, such as ligaments, a tight ligament. And we will come to that point. Shruti, let me know if I could clear you up in that manner. Okay, okay, let's assume that I cleared that up. If not, just text me again. So here I was asking, what is the capsular pattern for the wrist? And most of you guys told me that the wrist gets restriction in both. Okay, Shruti will come back to that again. Okay, just follow me here. And everyone jumped in and answered that the capsule, if it is a capsule that is at a problem, then in the wrist. Yes, I think Ratuja Mahale, go ahead and ask me the question. Or do we hold the question to the end of the session? Okay, no problem, Ratuja. So yeah, I was asking what is a capsular pattern for the wrist, and most of you guys told me wrist flexion and extension both gets affected in an equal manner. If wrist flexion is gone by 15 degree, extension should also go by 15 degree. If we see that, then we can tell, okay, the problem is at the capsule. Now, if you look at the picture here, picture on the right side, see that black dark shaded area, that is the restricted range. And the shaded area is same for the extension as well as for the flexion, right? And if you see this, then you can tell what structure is at problem. Go ahead and jump in, guys, in the chat box. What structure do you think is at problem if you see restriction both in flexion and in extension at the wrist? Capsular. Very good. So capsular. On the picture on the left side though, see the extension is only limited and the flexion is not limited. The black is just on the extension side. On the flexion side, it is not limited. Now, what does that mean? That means non-capsular. Joe, excellent, non-capsular. Now, what does non-capsular mean? Non-capsular can mean tightness in extensors. Aisha, no, most likely tightness on the flexor because extension is not happening. There is a limited extension. Flexion is good, but extension is limited. So it's most likely on the other side. That's the problem. Okay. So, but we will come to that. Here the thought process should be, it is not a capsule. It is something else, but not just a capsule. So we have, can it be due to fracture? For the non-capsular, of course, yes, definitely a fracture can be a problem as well, but we will rule that out. Okay, we will rule that out in a while. We'll come to that point again, how to rule out if it is a fracture or not. I'll come to that point. It can be anything but a capsule. Up until this point, we are just trying to find out if it's a capsule or not capsule. Okay, by just doing passive range of motion and you look at the restriction and the pattern of restriction, you can tell if it's a capsule or not. And what is it? Is it a ligament or tendon or a muscle? We'll come to that. Is it a bone or articular surface? We'll come to that. Okay, hold on to your thoughts on that, but just let me know if you understood this. Restriction in the capsular pattern, it's a capsule. If it is not a capsular pattern, it's not a capsule. Very simple. Just by doing a passive range of motion, you can find this out. Now, if it is non-capsular, then like I told you, it could either be coming from inside the joint or inside the capsule, or it could either be coming from outside the capsule, outside the joint, right? And what structures are inside the capsule and outside this capsule? Can you please write me down? What structures are there inside the joint? In capsular restrictions, active and passive range of motion in almost all direction restricted, right? Shruti, almost all directions. First of all, yes, active and passive, both range of motion will be restricted. Very good. And is it almost in all direction? That depends on what joint we are talking about. Every joint has its own pattern. For example, in the shoulder, how many movements are there? Flexion, abduction, internal rotation, external rotation. Yes, synovial fluid in joint. Very good, Manpreet. Yes, most likely it happens in the synovial joint. And why does it happen? That brings us to a next question. Why do we see a capsular pattern in a joint? It happens because when there is a synovial fluid inside the joint, the synovial fluid can either swell. Ratuja, I get confused between which structures will be affected due to affected active range of motion. We'll break it down. Hold on, okay? We'll come to that point. We have not reached there yet. We are just talking about what causes capsular pattern. So if this is a joint and this is the capsule, and if this is the capsule right here, suppose the synovial fluid is too much and it is swollen, and the capsule is already stretched. And since the capsule is already stretched, it does not have enough flexibility to allow range of motion. That is why we see capsular pattern, and we see this either in an infected joint, either in an arthritic joint, or capsule is just inflamed and it is shortened, or a capsule is tight. If a capsule is tight, or if the capsule has lots of fluid inside, then we see capsular pattern. And the most common cause is arthritis. It could be any other articular swelling as well, but that does not happen as often as arthritis does. So that is what the capsular pattern comes from, a swelling inside the joint, and the capsule is not flexible enough to allow range of motion in different planes. So coming to my question again, can you guys list me the structures inside the joint and structures outside the joint? In other words, can you guys tell me what structures fall inside the capsule and what structure fall outside the capsule? I'm trying to make you think here. Try to avoid seeing the screen right there. I got the answer there on the screen, but try to jump in and answer what kind of structures you see inside the joint or inside the capsule, and what kind of structure you see outside the capsule. Okay, guys, jump in on the chat box and just type in what kind of structures. Labrum, ISA, very good. Inside the labrum, menisci, very good. Jaw, excellent. So if you think like this, then you will be able to differentially diagnose. So inside the capsule, we see labrum, we see meniscus, we see joint surface. Sometimes joint surface might be just dislocated. Okay. And the outside the capsule, we see cartilage is very good. Cartilage is another thing that might restrict the range of motion. Now outside the joint, we see ligaments, we see adhesions, we see scar tissues, we see tendons, we see other structures, right? So moving on, now coming to your question here, Ratuja, I think you asked me, I don't know how to find out what structure and what range of motion. So here is a formula. When you do a passive range of motion, okay, when you do a passive range of motion and there is pain on the opposite side, when you do a passive range of motion and there is pain on the opposite side, then we are getting pain from anything that is getting stretched on that side. Does that make sense to you guys? Yes, Aisha. Osteophytes also, needy. So yeah, you guys, what I just told you is, if you move a joint in a passive range of motion and there is pain on the opposite side, we did a radial deviation and you have a pain on the ulnar side, and the pain is most likely coming from stretching the structure on the left side, ulnar side. And if that happens, then most likely the problem is the inert structures, non-contractile structures. For example, ligaments. For example, a certain area of capsule that is tight. I know I told you capsular pattern acts in a different way, but that happens when the entire capsule is affected. But if one area of capsule is just one area of capsule is tight, let's say a posterior capsule is tight, then it will affect the horizontal adduction, right? Let's say the ligaments on the posterior sides are tight, it will affect the horizontal adduction. Here on the wrist, if you do radial deviation and something is stopping the movement, then the structure on the ulnar side is at problem. If the patient gets pain, then we can tell that the pain is coming from the ulnar side ligaments. or online side structures. And there is one exception to this rule though. The exception is, I told you, when we do the movement and the opposite side gives you pain, then it is most likely inert structures, non-contractile structure. There is one exception to this rule. There is one exception to this rule, and the exception is, if your movement is sufficient enough to stretch the tendon or the muscle on the opposite side, that might also give pain, right? So it does not happen in the ulnar deviation, but it can happen in the wrist extension with your elbow extension. When you are extending the wrist with your elbow in extended position, you are not just stretching the capsule on the volar side, you are also stretching the tendon on that side, because now the tendons are also getting stretched. Does that make sense? So that is the only exception when you think of non-contractile structures. When you think of contractile structures. But most of the time, the passive range of motion will give pain when you move in an opposite direction, likely coming from the non-contractile structures. For example, ligaments or tendon. Here in this picture, if you look at this picture, in this picture, the person is doing radial deviation. And if you look at the radial ulnar side, there is tear on the ulnar side ligaments. And that will give the pain. Where? On the opposite direction of the movement. And when he or she does the ulnar deviation, there will be no pain. So what does this give? This gives us to another pattern. Earlier in a capsular pattern, restriction of range of motion in all direction. But if there is a restriction in one direction and that gives pain on the opposite side, it's most likely coming from the ligaments or anything that is stretched on that side. Okay? Just follow me, guys. I know it sounds so simple and basic, but we will use all this basic information to come to a formula. We'll come to that formula and we will use that formula for all the questions in the exam. Okay? Just follow me. Now, active range of motion. What do we see in an active range of motion? Up until now, we just saw passive range of motion. Up until now, we just saw passive range of motion. In the passive range of motion, we saw two things. One, we look for the range of motion, whether it is complete or non-complete, or it is more than complete. On another thing, we see pain and where the pain is coming from. In the range of motion, we saw if the range of motion is restricted in more than one plane or just one plane. If it is restricted in more than one plane, then that is capsule. If it is restricted in only one plane, that is anything but capsule. And how to find out if it is ligament or not? To find that out, if we move the joint in one direction and the pain is coming from the opposite side, then that is most likely ligament. Now you follow up onto this point, right? Just let me know if you follow what I just said. Okay, so very good. Now, having hold that thought, now we will look into active range of motion. What do we look in an active range of motion? We look for two things. We look for a contraction that's happening. When we are doing active range of motion of elbow, we are looking for biceps contraction. One, and we are looking for stretching that's happening on the opposite side. So when a person says he's having pain during active range of motion, you guys go ahead and jump in. What can be the cause? It could be, I will give you a starter. It could be the muscle that's giving the movement, right? Now you go ahead, yes, knee, muscle. Go ahead, and what else can give the pain during active range of motion? Just like we did in the passive range of motion, now here in the active range of motion, when you move a joint actively, what all structure can give the pain? Not just the muscle. I just gave you muscle as a starter. You go ahead and jump in and type in, what do you think can give pain in an active range of motion? Inflammation of joint itself. Okay, that's likely. Let's not talk about the disease or condition, but let's talk about structures. What structure can give pain during active range of motion? One is muscle. Another is, go ahead and jump in, guys. Tendons, yes. If the tendons are at problem, either the bicep tendon that is doing the contraction or the triceps tendon that is getting stretched. Very good. Fascia, very good. Karen, fascia, yeah, on the fascia on the other side, which is getting stretched, it could also give pain. Go ahead. What about the ligaments? This side ligaments are getting stretched, right? The capsule on this side is also getting stretched, right? So this can also give pain. What about the joint surface, the articular cartilages? Can that give pain? Have you seen an arthritic joint giving pain while doing active range of motion or not? Yes. So if there is a problem inside the joint, that could also give pain. What about the bone? Suppose there is a hairline fracture. Suppose there is some problem in the bone. That might also give pain, right? So it can also, the pain can also come from every structure. Just like passive. The only difference here is muscles are contracting on the active, and in the passive the muscles were not contracting. Now if you combine active and passive, you'll come to a formula. You'll get a system, you'll get a pattern, and you can rule out muscles. Okay, so I'll give you a scenario, a practical scenarios, and you can tell me. Okay, so I'm going to give you the scenarios. We are again looking for range and pain here. Like we did in the passive range of motion, we are looking for range and the pain. What happens to the pain when you move the joint actively, and what happens to the range when you move the joint actively. So if we combine that, let's say active range of motion is painful. Okay, don't look at the screen, just listen to me and answer me. Try to avoid looking at the screen, because screen has the answer. I want you to think. So let's say active range of motion is painful, okay, but passive range of motion is pain-free. Okay, Ratuja, your question comes here. Now I want you to answer. The active range of motion was painful, but passive range of motion of the elbow is pain-free. So what do you think is that problem? Muscle which is contracted, Aisha. Muscle tightness, Manpreet, not actually tightness, but most likely contraction that's giving a pain. Muscle, contractile structure. So on the muscle also, I want you guys to break it down. It could be from any attachment of the muscle. It could be muscle origin. It could be the muscle belly. It could be the muscle and tendon junction. It could be the tendon itself, or it could be Ratuja, very good. Muscle contraction on the same side, or it could be the muscle attachment on the insertion site. So anywhere if there is a problem, active range of motion will be painful, but when you move it passively, there is no pain. See, you are seeing a pattern here. Okay, so let me give you an example of each area. Let's say someone was playing arm wrestling, and during arm wrestling they hurt the origin of the biceps right here, and the origin of biceps, it not only pulled the tendon, also pulled a little part of the bone, periosteum, and you did active range of motion. That will stretch the periosteum more and they will get pain, right? Okay, so another example, same arm wrestling, they did the arm wrestling and they hurt the muscle belly here. Now there is some tear on the muscle belly, and you did active range of motion and it is painful, and you did passive range of motion and that is not painful, and you did passive range of motion and that is not painful. So again, a tear from the muscle belly could also give rise to the same scenario. Another scenario, the person is also doing a arm wrestling here, but the tear now is between the muscle and tendon junction. Same, active range of motion will be painful, passive range of motion will be pain-free. Again, same scenario, arm wrestling, muscle got hurt, but at the distal insertion point where the tendon is attached to the radius, it has some kind of tear in there, and you do active range of motion, it hurts. When you do passive range of motion, does not hurt. So the muscle or the contractile structure can get injured in any area or any site, but the likely pattern will be the same. It will be same for everywhere. Okay, so now I'm going to give you next scenario. It was just about the pain. Now I'm going to give you a scenario of range of motion. Active range of motion, let's talk about shoulder here. Active range of motion is partial, just up to here, 90 probably. But when you move it passively, it can go all the way up, right? Repeat again. Don't look at the screen. Screen has the answer. I'm going to ask you the question based on how you think. Active range of motion is just up to 90 degree, can't go any further, but the passive range of motion is complete, full. What do you think? What structure is at problem? Muscle weakness, muscle, contractile structure, muscle weakness, weak muscle. Excellent. So I know I'm asking you all this basic and simple question, but bear with me. This is going to give us a beautiful formula and we can use that to answer any question. So here we are talking about contractile structure involved again. So we can rule it out. We can rule the other structures. Now we don't have to worry about capsule. We don't have to worry about ligaments. We don't have to worry about joint. We don't have to worry about other structure unless there is other symptoms. Okay. Now let's combine another thing. Yes, Ratuja, when active range of motion is not full, we suspect a muscle weakness. If passive range of motion is full, not just active range of motion. Can it be passive range of motion full? Yes. We have to see for both, not just the active. If active range of motion is not full and passive range of motion is also not full, that's a different scenario. I'll ask you what that means in a little while. That means probably a stiffness. It's not a muscle, just the muscle that's a problem. Okay. It could be a joint, anything. We need more question and answer in the session. Yes, Dina, I'm going to ask you more question, but I'm just going to discuss first the basic concept, and then I'm going to use this to ask you the question. Okay, bear with me. We are going to use this formula to answer the question. Just answering question from the memory is not going to help. You have to understand the foundational concept, and I know we all know the foundational concept. This is very simple, but we need to learn to use that in all question in a systematic formula wise pattern. So let's combine here. Let's combine another scenario. Active range of motion is painful. Okay, guys, remember, active range of motion is painful. When the patient is lifting the shoulder, he says hurts. And the range of motion is just partial. He cannot go all the way up. He stops right there. When the patient is moving the shoulder, active range of motion is painful and the partial range of motion is there. Now, when you do passively, the range of motion is full and there is no pain. Now you combine these two findings and you tell me what structure is at problem. Let me repeat again. You are checking shoulder, you did the active range of motion, it was limited over here and it was painful. Patient could not go more. Painful and limited. When you checked passively, no Joe, capsule is not a problem here. When you do passively, if capsule was problem, passive range of motion should also not be full. So capsule is not at a problem because passively you can move the joint freely and there is no pain. There is no range of motion restriction and there is no pain. So the problem is coming from the muscle, tear of the muscle, could be anything, not just the tear, it could be anything. We'll come to that. Okay. Now next thing is active range of motion is painful. Again, it is painful, but range of motion is full. Okay. It is painful. Patients say, oh, it hurts, but then he can go all the way up. Now you did the passive range of motion. Passive range of motion is full and joint is pain-free, no pain. What structure is that problem? Again, muscle, very good. So again, muscle. But what is the difference between these two? One, patient can lift it up all the way up, but there is pain. The other, patient cannot lift all the way up and there is pain. What is the difference between these two? But the passive range of motion is pain-free and full range of motion. What could that mean? Not tightness, Nidhi. It's most likely the weakness, Damini, yes, but weakness is coming from some problem on the muscle. Now, which of the two scenarios has more problem on the muscle? Where the patient, one, let's say scenario one, active range of motion is painful, cannot lift up. Okay. Active range of motion is painful but cannot lift up. Passive range of motion is pain-free and can lift up. Second scenario, active range of motion is again painful but can lift up. And the passive range of motion is pain-free and can lift up. Which of these two scenarios has more or major muscle problem, major muscle lesion? One. Yes. The first scenario where active range of motion had limited range and then it was painful. The second scenario when the active range of motion was painful but he could complete the range. The second scenario, muscle is still at problem but it is not as worse as the first scenario. Does that make sense to you guys? But remember, we are again comparing this with the passive range of motion. Active range of motion alone does not give us this information. We have to combine this with the passive range of motion. When we do passive range of motion and we find no pain and full range, then only we can isolate and tell if it's a muscle or not, and then only we can isolate if it's a major problem on the muscle or not. Okay, now let me give you another practical scenario, ask you this question. Active range of motion is pain-free, full range of motion. Passive range of motion is pain-free, full range of motion. What does that mean? Normal. There, we don't have to worry about it. We can move on. Now we can think about other structures. Is it a joint? Is it a, let's say, is it another, let's say, is it a nerve that's at problem? Is it something else? Is this coming from a proximal joint? Not here. Is it coming from neck? Is it coming from some other part? So that means healthy structure. Okay. Now I know, guys, this is very simple and it might even sound silly. Just bear with me. We will devise a formula based on this concept and you can use that formula. Okay. Now, after doing active range of motion and passive range of motion, we could rule out whether it is coming from structures such as muscles or not. Right? Now, in order to confirm that, in order to verify it, in order to make sure that we are right, what do? We do a resisted isometric muscle testing. Okay, guys. And in the resisted isometric muscle testing, we do it in such a manner so that we put the joint in a midline position. We don't hold the joint either in full stretched or full flexed in that position. We hold it in the midline position and there is a reason for it. I will tell you why. The reason is, if let's say active range of motion is painful and you did a muscle testing, and muscle testing, yes, loose back position. We check we try to put the joint in a loose back position in order to limit stress on the other structures. For example, we don't want to stress the capsule. We don't want to put lots of stress on the cartilage. We don't want to put lots of stress on the joint surface. We don't want to put lots of stress on any other structure. We are trying to just isolate the muscle. In order to isolate the muscle and take the other structure out of the picture, we are going to hold the joint in a midline position. When you hold the joint in a midline position, now you need to also make sure that you avoid any substitution. Here in this picture, if you look at in the picture, the clinician is stopping the shoulder from hiking up. If he does not stop and the patient is bending the elbow while patient is also hiking the shoulder, then that means if patient says, yes, I have pain on the elbow, it could be coming from the trapezius or from the shoulder as he is hiking up, right? Yes. So when we are lifting up like that, it could also radiate the referred pain can also come down. That's why we need to avoid the substitution. Next is we need to hold the muscle contraction for 5 seconds. We need to make sure that we hold the contraction for at least 5 seconds. And why do we do that? To check if the muscle is weak or not. And with this resisted isometric muscle testing, again, we check for 2 things. First is the muscle strong or not? Next is is the muscle painful or not? Does the testing give you any pain or not? And combining those two things, you will come to a beautiful formula. Okay, now first, when you did the isometric testing, if you find muscle is kind of weak, what does that mean? That means either a muscle is at problem, muscle is not able to contract, or there is some pain and that is stopping the muscle from contracting, or the nerve itself is at problem. The nerve is not firing enough. And if there is pain while you do the isometric testing, you did active range of motion testing, it was painful. You did passive range of motion testing, no pain. And you did the isometric testing and it says pain. Then we can confidently say the pain is coming from the muscle. We can confidently say the pain is coming from the contractile structures. The only question that you need to ask is this the same pain? If they say yes, then we know it's coming from the muscle. Let's break it down. When you do isometric testing, I told you, you look for strength and you look for pain. And if you combine this, you'll get 4 options. One is muscle can be strong and pain-free, right? No pain but strong. Another option is muscle is strong but some pain, right? Another option is muscle is weak and some pain. Another is muscle is weak, no pain. And all of these means different things. And this is the formula I was talking about. If you know this, you'll be able to answer any question. So follow me again. I'll show you here on the chart. So you will see this matrix here. On the matrix number 1, look at the screen. Strong but no pain. What does that mean? Muscle is strong when you did the isometric testing and there is no pain. Muscle is normal. We don't have to worry about muscle. We can think about, we can now move to look for another structure. It could be capsule, ligament, joint surface, anything else, but it is not the muscle. We know for sure it is not the muscle. You need to make sure that the pain that is patient complaining is coming from the isometric testing, not a resting pain. When you do the testing, the patient says, yes, that's the pain I'm complaining. Okay. Next option is muscle. When you test it, it is still strong. Let's say out of 5, it is 5 by 5. Okay. But there is some pain while doing the testing. And the patient says, yes, this is the same pain I have. Then what do you suspect? Some problem in the muscle. We don't know yet. Just hold on to your thought. It could be any problem, but whatever the problem is, it is not a big problem. It is a minor problem, minor lesions. Why? Because muscle is still strong. Does that make any sense to you guys? Okay, so whatever the problem is, muscle is still strong and it is minor lesion. And the patient says, yes, that's the pain. Next option, next likely scenario we can get is muscle is weak. You get the muscle 3 by 5. Out of 5, muscle is weak. And it has some pain. Not some pain, let's say significant pain. What does that mean? The problem is again on the muscle, right? Problem is again on the muscle, but compared to the previous scenario, here the problem is bigger. It is a major lesion. It is a major lesion. It's not a minor lesion. Right? You guys get that? Okay. Now the third option. Muscle is weak, but there is no pain. What does that tell to you? Okay. I see denervation from Manpreet. Excellent. Nerve problems. Nidhi, I didn't get that CP. Do you mean to say complete? Do you mean to say complete injury? Yes. Okay. Yeah. Muscle is weak. Let's say biceps is, when you do the elbow flexion for the biceps, is 2 by 5. 2 plus by 5. But there is no pain. There is no pain. What can cause that? Not just the nerve, guys. There are some other things that can also cause. And that is musculocutaneous, no ratuza. If musculocutaneous nerve was completely gone, biceps would be 0 by 5, not 2 by 5. But you are thinking in the right direction though. Yes, nerve will be affected, but not a whole musculocutaneous nerve, because musculocutaneous nerve is the only nerve that is supplying to the muscle. So let's say C5 nerve root is gone, because biceps has C5 as well as C6. Let's say just the C5 is gone, or patient has a paralysis on the cervical spine and he just has muscle strength from the C6. Then the C5 supply to the muscle biceps is gone. That means you will get some strength. Cervical disc herniation, excellent, yes. If there is herniation and problem on just C5 nerve root, then it will be weak. It will not be 0 by 5. It will probably be 3, 3 minus 2, depending on how weak the muscle is. It will be weak, and there will be no pain with the isometric testing. When the isometric testing is done, the structure itself does not give any pain. Manpreet, yes, pain will be there, but on the neck. Remember, the key here is whether your isometric testing is giving the pain here. If you do the isometric testing and patient says, yes, that is the pain I'm having, then the isometric testing is considered painful. If you do the isometric testing and patient said, yes, I'm having the pain on my neck, that does not say the biceps is involved. That still says something is on the neck, not the biceps. We will still say biceps is non-painful. Does that make any sense, Manpreet? It should be, the pain should be coming from the structure that we are stretching. The pain should be coming from the structure that we are testing. Only then we will say it is painful. Okay. Now, what are the likely scenarios? Is a speech test positive, biceps involved? Ratuja, very good. What is a speech test? Nothing but a kind of a isometric muscle testing of the biceps, right? You're just doing a range of motion while giving resistance, and you're checking the stress on the biceps tendon. If it is painful, then we know from this just concept, you don't have to even remember the speech test for a fancy name. You just know what you are doing. You can tell what the problem is at, what structure is at problem. That's the beauty about knowing this pattern. Yes, all the special tests are designed based on this formula. So I was talking about weak but no pain. Okay, guys. One is nerve. Already done. Nerve could be involved. Another is, imagine the biceps is completely torn. From origin to insertion, the biceps is completely torn and there is no continuation, not even a thread of continuation. Okay? And when you did the test, what is the essence of testing the biceps with the resistance? You are trying to pull this out and the patient is trying to pull it in, and then the muscle gets tensed and then that gives pain. But since there is no continuity, when you do the pull and push, biceps is not taking any tension, no pain. So complete tear. Does that make any sense? Okay. Now next scenario, when there will be weak, labral lesion can be a cause. No Ratuja, no labral. It can be anything. But we are just talking about muscle. What's happening to muscle? Okay. Let's not jump here. So now another scenario when muscle is weak but there is no pain. One, we said nerve. Next is complete nerve, complete injury of the tendon or structure, whatever you are testing. Another likely scenario is inhibition of the muscle. Have you heard of that term, inhibition of the structure? When the muscle is inhibited, it happens very likely in the knee joints. If there is any problem in the knee joint, the biceps, so quadriceps gets inhibited. When you do the isometric testing for the quadriceps, muscle will be weak, but that test might not give pain. So it will be weak, no pain, right? So what does that mean? That means inhibited muscle. So 3 likely cause for that structure alone, but for that answer alone. Repeat. Okay, Aisha, let me repeat this again. We are telling muscle is weak, but no pain. And I was telling inhibition could be a cause. How? Inhibition is when the muscle is shut off. Muscle does not get enough firing. Why? We will just forget that. Why does that happen? We'll forget. If you want to know, I will tell you, but why does that happen? Let's forget. But what happens after that? What happens is when you do the isometric testing, your testing gives you two results. There will be no pain on the quadriceps because the quadriceps is perfectly fine. The structure has no problem. It is just inhibited and the muscle will be weak. Does that answer your question, Aisha? Got it. Okay. Due to GTO problem in muscle, Ratuja, excellent. Golgi tendon organ problem, most less, not GTO alone, but any muscle disease such as myasthenia gravis. Okay. Myasthenia gravis or neuromuscular junction problem, there is not enough acetylcholine in the neuromuscular junction and the muscle does not contract enough. Excellent, you guys are thinking now. Very good. So when the muscle is weak, there is no pain. That is also another likely cause. Okay, any muscle disease, any genetic disorders in the muscle and muscle starts losing strength, that is also scenario. Let's summarize what we just discussed. Okay guys, if you look at the chart here, I have 4 matrices, one for strength and weaknesses, another for pain and no pain. Option number 1 is we can get either muscle is too strong, 5 by 5, strength is good and there is some pain. And we said that likely means a minor muscle lesion. Now what is a minor muscle lesion? Maybe a small tear, maybe there is a trigger point, maybe some tendons are involved, tendinitis or tendinosis or any muscle spasms. Okay, does that make sense? So those are the options. If you see in the question, active range of motion painful, passive range of motion pain free, registered isometric muscle testing, you see strong but pain. Then if you see any of these on the option, that is most likely your answer. Either trigger points or small minor lesions of the muscle or any tendon problems, you will see this kind of scenario. Imran, we are talking about registered isometric testing and how can we isolate what structure is involved. So if you just follow along with this, we are just going to summarize what's happening here. Rest of the guys, please let me know if you understood what does a muscle strong and pain means. Got it. So Aisha said got it. Anybody else? Manpreet, yes. Any doubt on this? Yes. Nidhi, got it. Okay, now let's move to next outcome. When you test the muscle is weak. Okay, instead of strong, no, not TOEFL today, Imran. We are talking about National Physical Therapy Examination questions and how to answer in differential diagnosis. So let's talk about if the muscle is weak and it is painful. Okay, so what does that mean? That means since the muscle is weak, yes, myofascial pain syndrome can also be a trigger point. That means major muscle lesion. For example, grade 2 tear on a muscle or grade 2 tear on a tendon or anywhere in the contractile structure, there is a major muscle lesion. Then we will see a weak muscle but painful while you do the isometric testing. Shall I move on? You got this. And the next likely scenario, okay, Nidhi, Aisha, strong but no pain. We already ruled out the muscle. Muscle is totally fine. You don't have to worry about muscle. Just move on. It could be ligament, capsule, anything else, but not just the muscle. Muscle is not involved here. Don't worry about muscle. Perfect. And the weak muscle, there is no pain. I told you already, 3 likely scenario. Either there is complete discontinuity of the muscle structure. A. If you look at the screen, weak, no pain. Next is nerve damage. If the nerve is damaged and the nerve roots are involved or the spinal cord or any higher lesions are there, that is another likely scenario. Third is if the muscle itself is inhibited. And the fourth and fifth, you can just stretch. You can say muscle disease such as myasthenia gravis, any muscle tendon junction problems, anything like that. So are you guys clear up to this point? We just discussed a formula of resisted isometric testing. Now, if you use this formula and combine how to do this on a practical scenario, let's use the same concept on the teres minor. If you look at the picture here, the patient is kind of moving the arm into lateral rotation. Don't think he's doing the TheraBand. Instead, think a clinician is giving resistance. Okay, I could not get the picture of resistance testing for the teres minor. That's why I pulled this picture. That's the position that we will hold the joint at, and then you will give resistance, and the patient tries to move into external rotation. So the testing position is arm abducted to 45°, and you give resistance against the lateral rotation, and you stabilize for any compensatory movement. And I'm going to ask you, and you guys tell me what is the problem. Let's say muscle is strong and there is no pain. What do you think of a teres minor? Teres minor is totally fine. There is no problem in the teres minor, normal. Ratuja, Mansi, Joseph, Joe, Damini, normal, excellent. So there is no problem in the muscle. Next likely scenario. Muscle is strong, but there is some pain. Can you give me any diagnosis? What do you think would be the problem on teres minor? Minor tear. Trigger points. Manpreet, excellent. Minor injuries. Any spasm that's painful while contraction? Yes. Aisa Khan, excellent. Any tendon problems? Tendinitis, tendinosis, right? Okay. Next is muscle is weak and there is some pain. What do you think? Major problem in the Mansi. Ratuja, muscle is problem. Major tear. Aisa, yes. Major tear. Major problem. Manpreet. Muscle has some major problem. Maybe a grade 2 tear or something like that. Joe, grade 2 tear. Nidhi, excellent. So that gives us strong. So if you just follow that, strong and pain, trigger points in the teres minor or small lesion or minor tendinitis. Weak and pain. If there is a major muscle damage or there is a complete severe tendinitis or chronic tendinitis, because of chronic tendinitis patient lost the strength over a long period of time, that could also be weak and painful. Or there is a major tear on the muscle. Strong, no pain, teres minor ruled out. You don't have to worry about teres minor here. Weak but no pain. What does that mean for the teres minor? Give me likely answers. Inhibition, okay, excellent. Complete tear of the nerve. C5 and C6 involved. Okay. Myotome, okay. Axillary nerve. Axillary nerve injured, right? And how to differentiate between the muscle pathology? Yes, Manpreet. How to differentiate between axillary nerve and the nerve roots? That's another class. I don't want to go into there, but you just know it's a problem at the nerve. Neck of humerus fracture. Neck of humerus fracture. That's a lateral thinking on this topic here, Nidhi. Yes, I agree. If there is any fracture on the neck of humerus, not just the teres minor testing will be painful. Any testing, any muscle testing will be painful, right? You follow that, Nidhi? Axillary nerve damage, muscle pathology, axillary nerve. Yes, excellent. You talked about nerves, so yes, yes. Oh, yes. So when there is a neck of humerus fracture in the past and it is healed, and then the axillary nerve was injured, so you meant it that way, not an acute neck of humerus fracture. Okay, got it. Yes, yes. So, and the third scenario also, how to find out if the muscle is inhibited, or how to find out if the muscle or the nerve is at problem, that's another class. I don't want to go there. I just want to make it simple today so you can answer this question here. Now, based on that discussion, you should be able to answer not just this question, any questions like this. Shoulder, elbow, hip, knees, and everything. Go ahead and read the question and type in your answer. I'll be back in about couple of minutes. EMG or NCB studies to rule out. Yes, Ratuja. Go ahead and attempt this question. You should be able to answer this and we will discuss. So yeah, I see someone has answered the question. You guys can go ahead and answer and we will discuss it. We will break it down and we'll discuss it. So, Aisha Khan, Karen, Nancy, everyone answered correctly. So let's break it down, okay? So why one is the answer? Let's break it down. Here, we know the history already. Patient fell down and then they did an X-ray. X-ray was negative. That means bone is not involved. And he had a fall about 3 weeks ago. It's kind of subacute. And then when we do the active range of motion is just partial. He cannot go more than 35 degree. Okay. And when we do flexion and abduction, scapular elevation is noted. That means muscle is weak during the active range of motion. So active range of motion is weak, right? Active range of motion is weak. Now, look at the passive range of motion. What does the question give you? Passive range of motion is nearly full. Passive range of motion is completely full. That means capsule, ligaments, and other structures are not a problem. So you can rule out number 4 from that. Number 4 is gone because passive range of motion is full. Okay, Karen, yes, that's a good question. We'll come to that. Because there is a passive range of motion is completely full. There is no pain. There is some pain at the end. So we can rule out option number 4. Capsule is gone. So when we do resisted abduction, the muscle is weak. That means there is major problem and some pain on the anterior and lateral deltoid region. Any problem on the shoulder, pain will be on that area. It could be muscle, tendon, capsule, ligament, joint, cartilage, labrum, anything. So the area tells you nothing. It just tells you the pain is there. That's a C5 area. C5. Any structure that is supplied by C5 will have pain on the C5 region. Okay. So resisted abduction is weak and pain. Now, if you look on the options, there are 2 muscle problem. One is number 1, another is number 3. Number 1 is major problem. Number 3 is minor problem. Now, because our muscle testing gave us weak and painful, We are going to go with, yes, Ratuja, that's what I'm going to talk about. How to distinguish between 1 and 3. If it is strong and some painful, then most likely it is a tendinitis. But since this is just subacute, it is not chronic. Okay, it is not chronic, just happened about 3 weeks ago. So, and within that time period, the muscle gone so weak. That means there is some major problem on the muscle. So 1 is most likely the right answer. Hold on yet, we are not done yet. See, if you look at the history, what did the patient have? Patient fell down. He had a trauma. Yes, Mansi, that's what I was going to talk about. He had a trauma, and then it happened suddenly. He had a trauma, and then that is going to give you most likely tear, then the tendinitis. Here the history also helps you, but in question, when there is no history like this, even then you'll be able to answer this kind of question. You don't have to memorize those, tables from the therapy aid or tables from Maggie. If you know this, you don't have to memorize anything. You can do, all kind of differential diagnosis based on these 3 things, for the muscles or not. And the axillary nerve, you guys tell me why axillary nerve is not a problem here. Pain is present, okay. No dislocation, okay. But the most significant thing is no atrophy. Very good. See, question is going to give you all kinds of clues in there. The question itself tells there is no atrophy. That means nerve is not involved. Another thing is, there is some abduction range. Yes, patient is able to do some abduction range, active range. That means muscle is still firing. Just a thought. Ratuja, empty can will be negative. Empty can test, when we do a internal rotation and do a resistance, that is most likely test for supraspinatus tendinitis. And when we do that test, what happens is we position the supraspinatus tendon in such a way that the stretch tension is going to go on the supraspinatus, and with the medial rotation it is coming closer to the acromion arch. Medial rotation coming closer to the arch, and when you do the test, it'll be painful for the supraspinatus tendinitis. But here, since we are suspecting a rotator cuff tear, patient won't be able to hold there. It'll probably more look like a drop arm test. It'll probably go down. He's not able to hold it there. Does that make sense, Ratuja? Yes. So Karen, she asked why there is some pain during the end range. The question itself tells there is some pain because of the guarding or the muscle spasm at the end range. So that is why there is some pain. Otherwise, that pain is not coming from the resisted isometric testing. That pain is actually not coming from the resisted isometric testing. Instead, when we do the resisted isometric testing, the pain is coming from the muscle. But the passive range of motion pain that comes right here, since one muscle is gone weak, the other muscles are kind of trying to overwork and compensate and help. And those muscles will have lots of trigger points and spasm. And that pain probably is coming from, stretching some of the muscle or spasm from any of the muscle. That is not related here though. So I hope this helps you understand. So if you use the same formula, you can answer any joint, not just the shoulder. Elbow, hips, anything. So let's do a few more questions like this based on the same concept. But before we do that, I would like to talk about, we just talked about how to isolate capsule, right? We know how to find out if it's capsule or not. We check capsular pattern or non-capsular pattern, and we can tell if it's a capsule or not. To find out if it's a ligaments or not, what do? We do passive range of motion testing. If there is pain on the other side, and that pain restricts the range, then we can tell if it is a ligament or not, right? How to find the muscle? How to isolate the muscle? We do active range of motion, we do passive range of motion, combine the information, and we do resisted isometric testing. In using that formula, strong, painful, weak, painful, strong, no pain, weak, no pain. We can tell if it's a muscle or not. So we could isolate if it's a ligament or not. We could isolate if it's a capsule or not. We could isolate if it's a muscle or not. So now what about the other structures? How to find out if it's a bone or not? Pretty simple. If there is any problem in the bone, the complaint will be in weight bearing, right? Patient has fracture on the ankle, while weight bearing they have pain. The pain goes up, right? And without weight bearing, how can you test? You use the same concept. Let's say you're suspecting fracture on the radius. One thing though, with the bone pain, pain will never be referred. Pain will be always exactly on the site. If there is a sharp, exact, precise location of the pain, that is most likely coming from the bone. Next is deformities. Any deformities is most likely coming from the bone. If another thing is just compress the bone, hold the two ends of the bone. Suppose this is the radius. You hold proximal end, you hold the distal end and compress. What happens? It'll give you pain, right? And you hold one hand and you hold another end, you do kind of torsion or you kind of translate. What will that give? You'll get pain. That's how you isolate bone or not. How about the joint? Same concept. If there is a problem on the wrist joint, you are suspecting wrist joint, let's say active range of motion is painful. Passive range of motion is painful. You tested capsule, ligaments and everything, muscles, all are ruled out. No problem. Now you think of, could it be coming from joint surface? Simple way to test. You compress the joint. You hold one end, proximal end, next end, you compress the joint. If patient says, yes, that gives me pain, then what's the problem here? Joint surface, cartilages, or any fracture on the joint surface. So you rule out joint surface that way. Does that make any sense? If yes, I'll move on to other structures. Okay, so, how to rule out the other structures though? Okay, how to rule out the arteries? How to rule out the vein? They all have different signs and symptoms. How to rule out the nerve? Let's say nerve, okay? If there is any pinched nerve, how to rule out if the pain is coming from the nerve or not? Okay, for the nerve, we see either positive sign or negative signs. What is a positive sign? Positive sign is the sign that is positive. What is positive? Let's say someone has HIV positive. What does that mean? It should not be there and it is present now, and that is abnormal. Something that should not be there, if it is positive, if it is there, then we call it a positive. That is HIV positive, right? What is A positive blood group? He has an antigen A on the blood. It is not abnormal, but I'm just giving you what a positive means. So that's why he has that. We call it positive. What is a TB test positive? Someone who is not supposed to have TB, he has TB. That's TB test positive. So in the nerve, similarly, you see two signs that are positive signs: pain and paresthesia. We should never have pain. Our life should be pain-free. And we should also not have paresthesia, tingling, numbing sensation, paresthesia. So if you see positive signs, then that's coming from the nerve, always. Okay. Next is negative sign. What is negative sign? It should be there and it is absent now. That is negative. If there is a negative balance on your bank account, 2,000 rupees or $2,000, what does that mean? There was 2,000 before and it's gone. It's negative. So similarly in the nerve, what does a negative sign means? Loss of sense, no sensation, loss of motor function, no motor function, loss of reflexes or hyperactive reflexes. So these are the negative signs. If there is a loss of reflex, that's a peripheral nerve. If there is a hyperactive reflex, that's a upper motor neuron lesion. Let's not go into that, but just talk about negative signs. Absence of sense, motor and reflex is a nerve problem. This is how you rule out nerve or not nerve. And there are other things that you combine. Reflex is essential for nerve. Yes, iPhone. I don't see the name here. I just see iPhone. So yes, that is true. Reflex is essential for nerve. All the peripheral nerves that supply the muscle that will have a reflex function. Now, based on that concept, I want you to answer this question right here. Go ahead and read this question, give you about 1.5 minutes. I want you to come up with the answer. Okay, guys, I see someone answered already. Aisha said number 1. Karen said 3. Girisma said C. I don't remember supply 1 or 3. 3, 1, 1, and 3. So most of you have a problem with the 1 and 3. Someone even said number 4. So let's break it down. So you guys are all over the place. So let's break it down. Let's read the question and break it down. After treating a patient for trochanteric bursitis for 1 week, we thought it was a bursa. Patient has no resolution of the pain and is complaining of problems with gait. He has no solution and he is still complaining with the pain. After re-examination, you need to pay attention to these key things. We did a re-examination because now we are suspecting probably trochanteric bursitis is not even a problem. So therapist finds weakness on the quadriceps femoris. See, quadriceps femoris is weak. And there is altered sensation in the gluteal trochanter area. See, when there is a loss of sensation or sensation is altered, that means we suspect nerve, first of all, right? So that will rule out, what will that rule out? That will rule out number 4 and number 2. It cannot be joint when there is a sensation that is involved. It can't be joined when there is a sensation ruled out. That's how you can rule out either number 4 and number 2. And distinguishing between number 1 and 3 is just by knowing the dermatomes. Where does number L4 go? Where does number L5 go? L4 comes around this area. L4 goes a little on the lateral side, goes run down the leg a little bit downwards. So it is L4. It's just a memory game. If you know the L4, you know it. So the answer is L4. Now, same question here, similar question here. These are all questions from the therapy aid, guys. I'm not making this up. So I'm going to ask you another question. Okay, I want you to read this question and then try to answer as quickly as you can. So I'm very first time I'm understanding questions easily. Thank you very much. Okay, Aisa, thank you for joining. Yes, I'm glad that I could help you understand. So everybody answered number 4, and that's pretty good. You guys are right on. It's the right answer. So let's break it down. So here, first of all, this is also a real question from therapy aid. So here, let's break it down, guys. An overweight adult patient complains of right anterior hip and knee pain. So the pain is on the hip as well as on the knee. We are talking about 2 different joints here, hip and knee. So we have to rule out all the joints. And the first rule of differential diagnosis for any joint, any peripheral joint, is we first need to rule out the spine. we need to make sure that the spine is not the problem. Spine is not the culprit. Okay. So, and the pain is especially when weight bearing on the right side. When weight bearing, the pain comes. Okay. Now, lumbar active range of motion is normal and pain free. See, we are screening the spine to see if spine is giving any pain, because spine can give pain all the way down to the ankle, not just the hips and knees alone. It can give pain anywhere. So we need to first rule out the lumbar spine. Lumbar spine ruled out, no problem on the lumbar spine, and we are moving forward downward. Right hip, active range of motion and passive range of motion are limited compared to the left. So right hip. See, what did I tell you before? We need to look at the active range of motion and passive range of motion. Both are limited. Both are restricted, right? So we can tell for sure that something tight or something, is kind of restricting the range of motion, right? Hip, active and passive, both are affected. And right knee, active and passive are full and pain-free. So what does that mean? Right knee is kind of out of the picture because active range of motion and passive range of motion are both pain-free and full. Knee is not a culprit. Most likely hip is, because we found active and passive range of motion limited on the hip. Like I told you earlier in the class, when we see range of motion restriction, it could be coming from muscles tightness, capsule tightness, ligament tightness, or joint surfaces, cartilages. Anything can give limitation on range and with the pain. Now, there is no pain with the resisted testing at the hip or knee. So, because we know anything can give pain, we are trying to find out if it is the muscle or not. So, we did resisted isometric muscle testing for right hip and right knee. No pain and the testing is completely fine. That means muscles are ruled out. Okay. Now, our doubt about muscle is gone. Muscle is out of the picture. Now, next test we do is scouring test. Scouring is nothing but a fancy name for compressing the hip joint. You bend the hip joint into flexion and little into abduction and medial rotation, and you compress the femur onto the acetabulum. What you're doing here, you're compressing the joint. And with that scouring test, with the scouring, you do some motion as well. You compress the joint and rub it. Essentially, that's what you are doing. With that scouring test, it reproduces the patient's pain and knee symptoms. Patient says, yes, that is the pain I'm getting. When you did that, exactly that's giving me the pain. Hip joint distraction relieves the pain. When you distract the joint, patient says, yes, now the pain is gone. So what is the question telling you about? The question is telling you joint is at the problem. The surface of the joint is at the problem. Initially also, every weight bearing on the right side was painful. Bam, one clue. Next is active range of motion, passive range of motion, both affected, limited. Bam, next clue. Muscle is ruled out, isometric testing, pain-free. Knee is ruled out, knee, active range of motion, passive range of motion, pain-free. Bam, next clue. Third clue, you compress the joint and rub it. Patient says, yes, that's the pain. So most likely it is joint. But we will not just jump onto the joint. We have to rule out one after another. Why is number one, trochanteric bursitis not an answer? Can anyone jump in? We've already come to the answer. Pain location. Where is the pain? On the anterior side and the knee. On the trochanter, pain is mostly on the lateral side, right? Very good. What another clue is the question giving to you? There is one more clue that tells you the bursitis is with overuse, Manpreet. That is true, but the question does not say whether the patient had overuse or not. So we can't say for that. Nerve compression. No. So another clue the joint gives is, see how to test if it's a bursa or not. See, we answered the joint, this answer correctly. But if you have this concept, you can answer the other question that asks you about the bursa. What is a bursa? Bursa is a sac that is filled with fluid, right? When the sac filled with fluid, what is the function? It helps reduce the friction when the muscles are sliding. When the tendons are sliding, it reduces the friction. And if it is inflamed, every time we move the joint, what happens? Muscles and tendon, they slide over the bursa. Every time we move the joint, muscles and tendon, they slide over the bursa. Active range of motion, passive range of motion are limited, but we confirm it with the resisted testing. We did a resisted isometric testing for all the muscles, and when we did that, when we do resisted isometric testing, this is the bursa. What's gonna the resisted isometric testing gonna do? It's gonna compress against the bursa. It's gonna pinch the bursa. It's gonna pinch it. Since no pain with the resisted isometric testing, there is no pain mentioned over there. So bursa ruled out. One by the location, next by. So what I'm going to teach you here is, don't always jump onto the answer. If you know it, don't just pick that answer and go away. Sometimes there might be other things that you've been missing out. You have to always rule out. Next, why option number 2 is wrong? Why patellofemoral pain syndrome is wrong? Because we already ruled out active range of motion and passive range of motion on the knee is pain-free. No problem. Knee is ruled out. Patellofemoral syndrome is ruled out, right? Piriformis strain. Why is piriformis strain not a problem? Because we did a resisted isometric testing for the hips and it was no problem. What is a piriformis muscle? It is a hip muscle, and we already ruled out there is no muscle problem. That's how we say option number 3 is wrong. So don't just come to the answer, instead eliminate all the option and then make sure that you confirm your answer before you jump to the next question. Okay guys, hope that helps. Next question again. Now for this next question, go ahead and read this question and try to answer as soon as you can. So I see someone answered 2, three of you answered 3, Garima answered 3, Dr. Aneet 3, Nitika's iPhone 3, 4. Okay, so if you guys are done, let's break it down. You guys are all over the place. 1, 2, 3, 4. We got all 4 options. So let's see. Before we answer this question, let me tell you one thing. When there is any problem on the muscle, how to tell? We can tell by 3 things. Remember, this is a formula. We can either make the muscle contract, and then if the contraction gives pain, like resisted isometric testing, that tells us muscle is at problem. Next is, we can either stretch the muscle, and if that stretching brings the pain, then we can tell the muscle is at problem. Third thing is, we can poke at the muscle's attachment or muscle belly. We can palpate and poke and see if poking or palpating gives pain, and that is also going to tell if it's the muscle or not. So 3 things. One is contracting the muscle if it gives pain. Another is stretching the muscle if it gives pain. Third is poking the muscle, and when poking or palpating or touching on that specific site gives pain, that tells us muscle is at problem. Here, I know this was confusing because let's break it down. After completing an examination of the patient with the shoulder pain, okay, patient has a shoulder pain, no other information. Physical therapist concludes that the cause is subscapularis tendinitis. I'm sorry, I wrote scapularis, but that is a subscapularis. Okay, guys. And this is the real question from therapy aid. I didn't make it. This is a subscapularis muscle tendinitis. I assume you figured that out because there is no scapularis muscle. There is only subscapularis muscle, and subscapularis muscle tendon is involved. The clinical finding supporting of this conclusion is based on the discussion we did. If the question give you active range of motion, passive range of motion, resisted isometric testing, now you will be able to answer the question. But now here they don't have that information. You have to reverse think. You have to reverse think. They're already telling you subscapularis tendinitis is the problem. You have to think in a backward manner. So if subscapularis is the problem, if you have to do active range of motion, okay, what direction would you test it? Jump in, guys. What range of motion would you test for subscapularis if you have to do active range of motion testing? Internal rotation, internal rotation, internal rotation. Aisha said adduction. It is not a primary function. Adduction is not a primary function. It does help in adduction, but that is not a primary function. Remember, with the muscle, we have to always try to isolate. Okay, Mansi, internal rotation. Damini, internal rotation. So, with the active range of motion, we are looking for internal rotation. Okay, if you have to stretch the muscle, what direction would you go? External rotation. Opposite. External rotation. External rotation. If you have to palpate and poke, where would you palpate? Right there on the subscapularis muscle, tendon attachment, or anywhere it is attached, right? Right? When you palpate on the muscle belly, nowhere else, wherever it is touched. So option number 1 says palpation on the greater tubercle of the humerus. Greater tubercle is not an attachment of subscapularis tendon. It is actually, in fact, a lesser tubercle. Greater tubercle has a pectoralis major. So option number 1 is wrong. We will not. Can origin or insertion be painful? Yes. It can either be origin, insertion, muscle belly, tendon, anywhere in the muscle. If subscapularis is involved, anywhere. But the question says tendinitis. Here, because the question says tendinitis, what is a tendon? Tendon is an attachment towards the insertion. So we are thinking about the insertion site. Okay, we don't have to think about origin. Mansi, very good question. How to palpate tendon? Do we do some action of muscle or opposite? So very good question. And I do teach NPTE classes, and when I teach, the first thing I tell everyone is I give them the material and ask them to study MMT, stretching and palpation of every muscle. You need to know that, because you will see questions like this and you have to know where to palpate, and you have to know how to stretch, and you have to know MMT position for all. And that's a good question, how to palpate the tendon. But here, let's assume that we know that the subscapularis is on the lesser tubercle. So what you do is, you go towards the lesser tubercle, try to make the shoulder as relaxed as possible, and then you ask the patient to do internal rotation, give a resistance with the other hand, and while he is doing internal rotation, you try to palpate where you feel the tension, and you go along the tension, because when the internal rotators are acting, you're going to feel the tension. You go along the tension, and at a point, if you find the pain, that's your muscle. Let's say, for example, you want to palpate the pronator teres. Where does the pronator come from? From the medial side. It has two heads, one on the epicondyle and one on the ulna side, and then two head run and then attaches on the mid forearm. So if you have to palpate the pronator teres, you ask the patient to do pronation, you give resistance, and with the other finger you feel for the tension. You move along the belly of the muscle from all the way up to the origin to the insertion. While doing that assessment, you give some pressure. If your pressure gives pain, that's the muscle that you are having a problem with. So let's not go into that. Just wanted to answer Mansi how to palpate the muscle. So here we are talking about how to stretch the subscapularis. We go into external rotation, right? So how to stretch the external rotation? by external rotation. Sorry, subscapularis. There are two external rotators. One is 3, one is 4, right? And why one of the two is the right answer? In what range of motion do you stretch the muscle most, active or passive? If you have to stretch a muscle, because passive range of motion is always more than active range of motion, you can get more external rotation going externally this way passively. So option number 4 is most likely the answer here. But let's also, we ruled out option number 3. Let's talk about option number 2, painful resisted shoulder adduction. Someone answered that, painful resisted shoulder adduction. And I know what they thought. They thought is, since we know that resisted adduction or resisted isometric testing, if it gives pain, that's the answer. Not always. You need to make sure that the testing is done for that particular muscle. Adduction is not a function of the subscapularis. It has a secondary function. It can help in adduction, but that is not a primary function. We cannot 100% sure tell if adduction is painful and confirm that the subscapularis is at fault. We have to isolate. If you have to do resisted isometric testing, you have to do into internal rotation. And when you do internal rotation, also there are pectoralis major and other muscles. But with this question, there is no internal rotation resisted isometric testing. There is only adduction. That's why option number 2 is wrong. And we have option number 4 as our right answer. So I hope that helps you guys with that, how to rule out muscle. 3 things. You can either make it contract, and when I say make it contract, make sure that you are making just that muscle contract, no other muscle, no adduction for subscapularis, no adduction for subscapularis, no other secondary movement. We have to make sure the muscle contracts. Another is we stretch the muscle. When you stretch the muscle, you know if the muscle getting stretched gives pain, that's the pain, that's the problem. Another is you palpate and poke the muscle, and then you can know for sure what is giving the pain. We already discussed this, talking about other structures, how to find out, how to rule out if a muscle is at problem or not. We do 3 things: contraction, stretching, and palpation. If that gives pain, that's the muscle. For the joint cartilages, active range of motion and passive range of motion, both will be painful. Compression on the joint or weight bearing will be painful. For the bones, any sharp pain at an exact location, any weight bearing or any compression, that is most likely coming from the joint. We did this. So guys, I wanted to talk so much today, but because of the time limit, I could only talk up to here. I hope that helps you answer the question for differential diagnosis, to find out what structure is that problem. You get this kind of question so many times because every joint has every muscle, capsule, ligaments, and everything. You can use the same concept anywhere and you can find out. I think someone said someone is taking exam in August, right? Yes, Nidhi and Priya. I hope you guys, okay, Mansi too, Grishma too. I hope this will help you answer question better. So you guys, I hope this session helped you, and for all the rest of you guys, and even in all of you guys, I do take license exam preparation classes, and my classes are pretty much like this. I deal with the basic, I deal with the foundation, I give you formula, I give you pattern, and I let you answer the question based on that concept. I will not make you memorize anything. I will not make you memorize any charts or anything. This is how I teach. This is how I make people learn. And I'm offering $100 gift voucher for a promotional period right now. And if you want to get hold of me, for all those who attended this webinar, I'm giving $100 gift voucher. I used to charge $400. Where to read MMT and palpation? Mansi, yes, you can read MMT from Kendall, palpation from any palpation book. You can, the one that I like is the muscle and joint palpation from Joseph E. Masculino. He's a chiropractor, but the book is phenomenal. And anyone who's interested to take the classes with me, just drop in the comment yes, and then I will write you down. I'll sign you up. I'm giving you $100 off for being such an awesome guys to join me here this Sunday. And you can reach me on this contact as well. I usually cover a basic like this and help you understand, learn better. I usually take two to three classes, but there is one person in my class who's taking exam in August, so I'm taking more than that for now. And my classes are like you join in and then you take it. As long as you don't pass it, I'll have the recorded session and then I can pass it to you, and then you can join me for next cohort or anything like that. And you can reach me on this email, score NPTE. Yeah, what about other topics like cardio and other topics? Yes, I do touch them briefly. I do help you understand the basic foundational thing, and then I do cover the other systems and cardios and pulmonary and everything. I help you because in physical therapy in the United States, we are not treating cardiopulmonary patients with that intensity as we do the musculoskeletal. Most of the majority of the question in the exam comes from the musculoskeletal. If you have a sound musculoskeletal, you'll pass the exam with flying color. Only thing that we need to look for is for the cardiopulmonary and other system, we need to look for the contraindications. Yes, Aisha, you said we can pass. Nidhi, any tips for the August takers? How many classes in total? How valid is the course? Yeah, the classes will be every week, about 2 to 3 classes a week. And then, like I said, we will cover all the topics for the musculoskeletal system and cover the other system, cardiopulmonary, briefly going over the foundation so that you can answer those questions as well. And the classes, how valid is the course? I didn't get the answer. If you mean for how long? Okay, for how long? As long as you don't pass the exam, you can join me because I take the classes every session with new students. Every session I take classes, and as long as you don't pass, you can keep taking the classes as long as you want with the same payment. And you'll also have access to the recorded classes, and you'll have everything, all the topics covered on that recorded session. Ratuza, fees are $299. Before I was charging $400. Now I'm just giving it $299. I'm offering a $100 discount. Any question, guys? Yes, Aisha. Yes, you said you were interested and you messaged me already. Yeah, let me know whenever you're ready to start. We can sign you up for the class. Like I said, I already have a lady, a few other students that I'm taking classes, and then one of them are taking exam on this August. So you can join at any time, and the classes are ongoing. Okay, yeah, you can message me on private messages, no problem. So I'll just hang in here until you guys are all, signed off. Just let me know if any of you are interested, if you want me to clarify anything. When are the classes?